Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator. This is session number 196. We have a truly exciting case for you, a bifurcation calcified lesion, which in many ways is bread and butter for Dr. Sharma and Dr. Kinney. But for most of you, you will pick up many new techniques. You will understand how a stepwise approach is taken, and should you have a possibility, just open the app also to supplement your education. You're also going to get a didactic from Dr. Sharma about I think it's PCB today and some other information regarding the CPK evaluation and numbers from acute MI. With that, let me take you to the cardiovascular lab where Dr. Sharma and Dr. Kinney are standing by. Samin, Anu, good morning.
Good morning, my friend. Good morning. And good morning to all the viewers of CCC Live. I'm sorry for a little late, but we are ready to show again bifurcation case. This one is both branches are very calcified, and with myself and our fellows, Prithvi and Kushal, and the rest of the staff is the same. RV and Will as the nurses, and CVT Asif and Nera, and imaging is Kiski. So this is the case. Actually, if we can just show the angiogram, I think right away, because I asked Anu that what are we showing differently this time. He said, well, this is a case with the both vessels very calcified, and a long lesion. It's like 111. Is lesion starts way before with the calcium. Maybe something different in terms of the teaching will be shown in this particular case. With that note, I think we start, knowing that we are a little late here. If we can go to our slides, this is still continue our accreditation. Rest remains the same way, operators, faculty disclosures, and our support. So this is the case, said case number 196, 4 away from 200. 78-year-old female with the very little risk factor of hyperlipidemia and controlled diabetes, mild symptoms, SAQ score 93, more than, towards 100 means very little symptoms, and the patient has a diagnosis on the high calcium and positive CtFFR, normal ejection fraction, one or very small medications of the diabetes control and so. And cath about few months ago showed two vessel disease of the RCA-RPDA and LED D1 bifurcation, which we are showing today, and with the ejection fraction of 61%. The patient had a PCI of the PDA, was started on clopidogrel. They always do the PRU, which is 169. Anything less than 238 is good, and patient is here now for the intervention of this both imaging guided, both LED and diagonal bifurcation. It will make it to appropriate because of two medical therapy, and patient has FFR of less than 0.8. Now question always comes, if you have a CtFFR positive less than 0.8, do you do the angio FFR? As you know, the Medicare does not reimburse you. If you have a CtFFR positive, other insurance companies are okay, but Medicare does not reimburse. They say that CT is quite predictive, and if it is positive, you don't need not to do the FFR. But many times I personally feel that it overreads it, because there goes very diffuse distal disease, mild disease, and it becomes positive. This matter of fact, this Sunday I had two patients, both CtFFR positive at the LED, and lesion was barely 20%. And we do.
That used to be a problem more in the circumflex distribution. You're noticing it even in other areas?
LEDs, because you know what they do somehow, although they should be able to give the gradient. Now there is clearly a new system compared to heart flow, and that actually is going to give you gradient of the any lesion rather than giving us the complete FFR. And they say that gradient of 0.2 means gradient drop of FFR of 0.2 means significant. But I have seen a lot of LED positivity with the minimal disease in the LED, and we repeat the FFR, and that's negative. So with that note, we are here, and with the 7 French guide, and trying to wire the LED because of calcium. Question is imaging before or only after the rotablation. Your catheter is too far in.
Just before you started, you made a statement that the lesion looks worse.
No, the thing is, that's not exact. I went and checked the old views.
Yeah,
And
good.
it's the same or different
No,
views level?
no. That they didn't have that kind of a cranial angle. That may be the reason we did not see it. But anyway, imaging will tell us right now.
Yeah. Looks to be significant disease even in the ostium, no? Or very proximal. But,
Yeah. And very tortuous distal LAD. And this, I'm sure, although this is a tight lesion, but compared to some other which I mentioned, that barely you can see the angiogram and nothing. And now you're going to IFR, no, IVUS of the LAD or diagonal?
Diag later.
I see.
So let us do the.
Samin would like to welcome several people from the Kingdom of Saudi Arabia and Pakistan.
Beautiful.
Welcome to you all.
Welcome.
And we've also, I got a personal feedback that the imaging sessions are being very well received.
Yeah. Oh, yes. Big hit. We needed a timely, because a lot of people just want to have a lot of discussion on there. And besides the teaching that it starts in time and stops in time. That's on top of it. But I will learn few things from there.
You know,
yeah.
The diagonal is almost as big as the LAD.
Yeah.
Yes.
I think we use the 1.75. Are you want to do IVUS now or after Rota? I think you do 1.75 first. Yeah.
No, it says, I know you like aggressive. So let us teach imaging guided. So let's do the IVUS.
Yeah.
So you know how you are going to select the bar. And where is, do we have that algorithm, Kiski, ready?
Yeah, it's ready. Do we show it?
Kiski, welcome to the webcast. Please continue. You have a dedicated audience already on CCC live cases.
Yeah.
Thanks so much, Dr. Madam.
Very good.
Okay, get us IVUS.
Okay, you plan to do IVUS on the
No,
rotawire?
I'm just on the rotawire.
Wow.
What I'm trying to teach is, I think many people always keep ask this question, how to decide the burr size. And we have been teaching that. We are looking at the vessel size, from our eyes, EYE, IVUS, okay, EYE. But for the younger generation, I need to teach, if we are doing imaging, based on the imaging, how can we select the burr sizing? So you have it? No, this is for this is calcific coronary lesion. So if you see there, see the first, right? First part is that if the now IVUS catheter does not go, so now the question also is, it's on the rotawire. Hopefully it will go, not on the regular wire. If it does not go, there is no question, you directly go by atherectomy, some kind of atherectomy device.
Exactly what Dr. Sharma has been mentioning for years. If the balloon or the IVUS doesn't go, proceed straight with ablation. I just remember even Kiski would enjoy, I've not had a chance to mention this. I think in 2012 or 13, I was helping create a nationwide STEMI program for China, and I had stopped for a day in Tokyo.
Can you change
I'd forgotten a hospital, and they even then, they were doing 100% of imaging guided. 100%.
I start pullback.
Wait.
Yeah, okay.
Yeah, Japan actually is still.
No, don't do anything. One second.
Overall, country-wide, Japan have 87% imaging guided. One of the highest. Yeah.
13 years ago, they were doing 100%. Unbelievable.
Yeah.
Unbelievable. So they are teaching the world and leading the world in many areas.
Yes.
Okay, now you can start.
Looking, do we take the ostial left main? No.
Yes, you're going to check the ostial left main.
Okay, sure. Check the image. Okay, start pullback. The first pullback. Yeah, already there, 360 calcium. Yeah, 360. Diffuse plaque, bifurcation. Yeah, stop it.
Okay, now let's go to the tightest area. So go back to that algorithm.
Sure.
Okay, tightest area.
Tightest area is the mid part, is like a 2.4 cross-section area, but around here definitely 360 calcium.
Yeah, 360.
It's very tight, a level of the bifurcation.
At the level of the bifurcation, go back.
Okay, one second. So first, this is the left main bifurcation.
It's okay. No, go to the LAD diagonal bifurcation.
Sure. So this is a proximal LAD, and this is the first branch from the 1 o'clock. This is a D1.
Yeah.
So around here is also like almost 360 to 70 calcium. This is the level of the LAD D1 bifurcation.
Okay, now go to the tightest area. Can we?
Actually, tightest is after the D1 bifurcation.
Yeah,
Okay.
that's exactly.
Yes.
Yeah. This is the level of the, I think, the septal branch.
Yep, that is correct.
Yeah.
Just stay in one point where it is tight.
Yeah.
Yep.
Okay, right there.
And the MLD is like 1.5. Minimum movement diameter is 1.5.
So if you go with that SS, it has to be 1.5 bar. Go back to that place again and show us the diameter. Tightest area.
Yep. Here, the AI said, 1.5 is the minimum MLD here to here.
So MLD is already 1.5.
Yep.
Okay.
Correct.
Samin, many questions. I'm going to try to just give
Go
you a
back to the
summary of
algorithm.
those.
Yeah.
Most of them are talking about the choice of ablation here, lithotripsy versus rotablation. That's one. And number two, just to let you know, we have got 33 people watching us now.
I told you. Yeah. What want to complete this so then we go to the work?
No, so based on, so you figure out the diameter, right? So it is not deep. So it is superficial calcium.
Yep.
Okay, if you have to understand more deep or no, of course, OCT is better. So we have superficial calcium. Go to the next.
Who's playing me? 1 second.
Or you have it.
No, there. Yeah.
So here is just based on the IVUS. You see that? Arc is definitely greater than 270.
Yes.
Then you have length we are not going by, but what we added was the more of the diameter, which actually comes when you are in the calcific nodule. So the diameter we showed is 1.5. As says, based on our algorithm, you should probably pick a 1.5 bar. But then nothing wrong in going 1.75 bar. Okay, that's number one. Going back
1.75,
up to the idea there, can we do OA? Can you do OA? Can you do IVL? Of course you can. One thing we do not promote and we do not teach is that if that you do a small balloon and then do rotational atherectomy.
Or just try to see a balloon only. So
Yeah.
question is, as you can see here in this algorithm, once you have imaging points of 2 or above, 3, 4, the scoring, those cases you can do a balloon, but you'll then repent it because we know that 15 to 20% failure rate, and now then you're talking about the bailout atherectomies and IVL. So question is, somebody wants to do IVL? I think this case probably IVL will go without pre-dilatation. That's completely okay. But what we do usually is do the rotational atherectomy. We know it's dependable, it's going to cross it, where IVL may not cross. And sometimes balloon, very calcific lesions, unless you pre-dilate, which was done in the CAD trial, disrupt CAD3, almost 55%, routine life maybe even more. Then you do IVL, maybe a little troublesome because it's a ruptured balloon has created a little bit of diastasis. So we try to use with the circular calcium, which is 360 degrees like this, do the atherectomy, and if you need to be, then combine with the IVL. But yes, somebody wants to do IVL, that's okay. Somebody wants to do OA in this case, that's okay.
Two more questions here. One, I'm going to read it to you exactly how it is written. This is from Nikhil Jha. Nikhil, thank you again for joining us. On imaging, if there is diffuse left main disease, then how do you interpret as there is no reference segment?
Yeah, diffuse
You want
left
to
main.
change it?
No, this will be okay. No, this is okay. Just plug, unplug again. Yeah.
Going back 1 second, going back to that our imaging, go to the distal part, because I suspect after the septal, I know there's disease, then it is then is there a bridge?
So not clear bridge, but definitely there is a size gap. After the septal vessel size is like 2.75. Yeah,
Right.
and Dr. Kenny, start of the pullback, I see some thin bridge. So it's true, there is a bridge. So start of the pullback point, there is small bridge. Yeah, there is a small myocardial bridge.
Yeah.
Excellent.
So angiographically was bridge, and you can see it very well. That is another reason.
Very nice pickup. Very nice pickup.
No, that is the other reason I wanted 1.5 bar. And I will be very cautious. I think SS we have to just do at the level of the bifurcation, not to go at the level of the septal, because then we are entering the bridge. And when a bridge, there is no calcium, and definitely do not advance a rotabar there.
Samin, all along you have advocated the strategy of a single burr.
Yeah.
So with that in mind, is 1.5 probably it almost works out to be a default.
Yeah. Yeah. I mean, most of the cases 1.5 default is good. And in this case, I think 1.75 we selected for the LED. I think we can use that also for the diagonal, which is a short lesion. Secondly, question was if you have diffuse disease of the left main, how do you do? No, remember, many of the parameters are absolute. That you have a MSA, MLA there, or whatever the lumen is. So it is all dependent on your vessel itself. It doesn't have to be comparative.
So if it's less than 5.5,
that's it.
It's severe.
Yeah,
okay.
That's right.
Like to also welcome Akib from Jammu and Kashmir. Akib, thank you for joining us, and we hope this spreads the good message.
Yeah.
And we've got a few people joining us from the Philippines.
Beautiful.
What is the burst speed there?
150.
I think I am coming out now. Okay.
Yeah, it's done.
Okay.
Yeah.
Come out. Give me the fielder wire. Let me go to the diag.
Sorry. 1 second.
Run through for the LED. So I will, let's image the diagonal.
Till we come out.
Huh?
We don't take the clip out till we come out.
Yeah, cannot.
The wire starts spinning otherwise. It has to be once burr out, then only you take the clip out.
Samin, you made that statement to the fellow?
Yeah. Yes.
Excellent.
Because very ready to come out, they thought the wire has come out, but no. Burr has to come out before, otherwise the wire will spin.
Right. It's holding the wire in position.
Yeah. So now what you want to do now? You want to
I'm going to
image the diagonal you mentioned.
Yeah, but I will, get the run through. Let's image the LED. If you're done good, we go to the tag.
Yeah. And do little modification of the plaque now for the LED to stabilize. You can always do a balloon, 3O balloon there. You want to take a picture? There's no need for picture.
Polishing run.
Yeah.
You want to take up Sine?
Yeah.
Okay.
Good.
See that area just before the bridge, what we stayed away from it.
The distal left main and the ostium of the LED is looking.
Yeah, I know this was not there before.
Very disconcerting.
No, was there? It's there before. What day we didn't show? Kiski?
Yeah, so actually distal left main has a lot of plaque, but area-wise 7.2.
But lumen is 7.2.
Yes, and osteo LED is like this, a lot of plaque, but area is like 4.8, but a lot of plaque in the osteo LED, so diffuse plaque in LED.
So how, Kiski, what would you, let's say, for the left main you have a 5.5 cutoff. Yeah. That almost translates into something close for an ostial LED also, no? The distinction between a very distal left main and ostial LED is so arbitrary.
Yep, that is correct.
Yeah.
Yeah, but if the lumen he's saying 7.5
exactly.
there, but
738, yeah.
Okay, you want to do what you want to do now? First, wire the diagonal?
Yeah.
Or you want to, okay.
Let's get the IVUS of the LED now, and then we will do the IVUS of the diag also.
There's another
more
question
important
for
here
you.
Is the IVUS of the diagonal, yes.
What percentage of your rotablation is a single burr?
I would say 95%.
Such a remarkable statistics for our viewers. So many people kept asking about the number of burrs and the size. So there is the answer, and almost all of them would be 1.5, no?
Yeah,
most of them.
Yeah, most of them. And more important is even if you use a 1.25, that's good enough. Just do the balloon and leave the rota wire there. If you cannot open it, then only you upgrade the bar or use the IVL. So I think this day and age, to me, we are still working on that paper that has introduction of IVL improved our rotational atherectomy outcome. We're working on that,
magic fingers with the guide wire, no torquer, nothing at all, just unbelievable.
What do you want to do, LED or diagonal?
We go LED,
okay,
and then I go to the diagonal.
So trying to see some cuts and lesion modification of the LED.
Anu, in your mind here, the biggest distinction in choosing rotational versus IVL was the IVUS demonstration of superficial calcium, correct?
No, yeah, that's one.
And the 360 degrees also, well, that is okay for
that
both.
can go for both.
Both.
No, I would say it is our comfort level.
Comfort level, and I can tell you from
someone who is just beginning and they want, to use IVL here, this IVL was okay choice here.
Did not
Anu, both of you, another lovely question coming again from Nikhil Jha. If there is simultaneous intimal calcium...
You did not put it correctly.
Nothing to do with that.
Yeah, now go. That's good.
No, it's not.
Pull back and go in again.
Samin, I'll repeat the question for you. If there is simultaneous intimal calcium and adventitial calcium, then how do you pick adventitial calcium on IVUS?
Yeah, no, IVUS cannot pick adventitial. If it's only the OCT. So really, so see now with because of the second wire, I think
No, it's nothing second wire. It's just it could have, see there? There's a separation between the wires.
The IVUS is not going now.
Yep. Yeah. Okay.
Good. Okay, I would
let me try the IVUS of the DAG.
Okay.
If they want, that's it.
Yeah.
We are not. I mean, ideally, if I was doing this case with a fellow, rota will wire, we dilate, cutting balloon of the side branch, 2 stents and out.
So we are going to do IVUS of the diagonal now.
Sure.
So question was, why the IVUS went pre-rota and did not go now?
It's we have created probably a small shelf of calcium. Remember that it was almost 300 degree calcium, not 360, 300. Disrupted that.
And actually you see that disruption after the cutting. So after the bifurcation, actually, if you see, there is definitely a disruption. We'll show that in 1 minute. But let's see now we are doing the IVUS of the diagonal. Even there it's not good.
Another
close.
Okay.
Yeah.
Can you see the IVUS of the osteum?
I checked the image.
Look at that.
So looks like it's the proximal LED.
It's still proximal LED.
Is your IVL use same, decreasing, increasing? This is a very, very unusual and a very good question.
You mean IVUS? No, we are about IVL use. No, IVL use actually us is very much increasing because we are in the randomized trials where the IVL is provided free.
Okay.
So that's one of the reason.
Very big incentive.
Very big incentive. But otherwise, our IVL use has been around 10%, 10 to 12%. Our rotational atherectomy is 24%. Yeah,
3 or 20.
24%, and I think what will happen is the most of the IVL or of the 10% IVL we presented in our paper rota versus rota plus IVL, the majority, I think almost 80%, 70-80% of our IVL is after atherectomy, not standalone.
Intimal disruption or calcium disruption at the inferior part of the ostium of the LAD there. Something is...
Or at the bifurcation, I'll show you just, let's say...
It's inferior part of the bifurcation.
Yeah, exactly. Yeah, this is the one. That's where it happened.
Yeah, truly complex lesion. Its entire segment is diseased.
You want to get 2.5 compliant balloon?
Yes, okay, good. So you see that? That was that disruption.
Yeah.
Maybe even, we never saw a nodule before, right, Kiski? first run?
Nodule,
Okay,
I don't
down.
think they get protruding too much. It's a 360 calcium plate, calcium sheet.
Mm.
Some part is eccentric.
Let me go up again.
Okay, careful. This is a
Just you were very close to that
Bridge.
bridge.
down. Okay, now you want to go high pressure here. Go. How high you went? 20? 22?
Yeah, we can go 20 now.
Mm.
Good.
So I don't think the way wait, balloon has expanded.
Now you can do the IVUS of the diagonal now, maybe. Because I think the whole case is that do you need to do atherectomy of the diagonal, or you can just do a cutting balloon or non-compliant balloon.
IVL.
Let me show that what I meant earlier. See this now? We are going to show. So this is the lesion in the LAD. Sorry, this view. Look at the 3 o'clock kind of between 2 and 3, that between calcium at the level of the septal, right? Tight lesion. Now we do a IVUS that time and then atherectomy, and look at the after atherectomy. As if it became lesion that area, just after septal, as if some shelf had been created. And that was the one gave us the trouble, we needed a balloon. Now, you want to do let's do the IVUS of the diagonal. I think that's the case. Sure. That was the whole purpose. You selected this case, that do you need to do a atherectomy of the
diagonal we will decide based on the imaging now. We'll do the cutting balloon or IVL.
Yep.
Anu, angiographically, if you take a look, there doesn't look to be much calcification in the diagonal, but I think it will be there, but maybe not that severe.
And if it's just short, just at the ostium, then you can do either IVL or just the cutting balloon. Okay. Actually, you know what, the very interesting, Samir, you just said. In the original angiogram, it looked like a lot of calcium in the diagonal, but here it looks to me, angiographically none. I mean, mild. Just a little sheet of calcium, which only you can see on the, when the cardiac salute is moving. So, level class,
Just to give you a feedback of how the audience feel, several of them would have selected IVL here.
Yeah, no, there's nothing wrong in that.
Yep. I think what Dr. Kinney mentioned, it depends on your comfort level. Sometimes between two comparable techniques, that's a deciding factor. Plus, of course, I think you have to be mindful of the cost.
Yeah, and that is why I say the big issue happens. Now here, justify to do a rotational atherectomy because IVUS did not go. That's one. Secondly, part of the many decisions we make, IVL versus atherectomy, that is still, IVL is not reimbursed by uniformly, particularly if it's the outpatient IVUS, ambulatory, there is no IVL reimbursement. And some of the other companies do not reimburse IVL, which is a 4,500 compared to rotational atherectomy, which is 2,000. Yeah, what do you want?
There is a 2,512 compliant balloon.
No, but we want to do atherectomy.
What atherectomy?
Rota of the diagonal. That was the original plan was. One second. You want to see that? That was the original plan. Let's take a picture. Do it, and then let's see how much calcium it is. Yeah.
It could be just a cutting.
I will use 1.5 bar. I think that was the whole plan was. Yeah.
One of the observations I have.
IVL.
Will not go. Yeah.
That's why I said, can we just pre-dilate IVUS again and do IVL? We are showing how live case normally are done, but compared to what we would have done with the fellows here.
Another lovely observation. IVL has virtually no learning curve compared to Rota.
That is correct. And so therefore IVL is not the issue. Here problem is if you do IVL, you discharge the patient. There are a lot of, and not every insurance company reimburses. And there are a lot of little different practice compared to out of USA, where everything is what you do, you are paid.
That is a 2,512 balloon.
Pretty nasty decision in the mid LAD also after the diagonal.
Yeah.
No, I would not say no learning curve in IVL, because one, you have to know that you have to use the right size balloon, for which imaging is always a must. So you have to understand imaging and the calcium before you say, okay, I will use IVL based on angiography. That's one. Though the company says for the IVL, right, that you can, even if you are going to an area which has a mild calcium, it's okay. We have had cases, especially at least 3 live cases where you can see deep intimal dissection as well as um, cuts, which I always worry about. When you stent it, there's a risk of perforation. So you have to exactly know the size and how many pulses you can give.
So one of the region which you point make of fluoro. See this now. Now this is the case we change from rotablation of the diagonal because see the LED dissection, we are afraid now or concerned, I would say, taking the wire out. So now we are going with the
Right.
what 2.5 balloon.
This is exactly where the
Bridge.
prediction of bridge was. Yeah.
Yeah.
Okay, down.
Okay. The ostium. Now you want to do IVUS and then you decide about IVL or not, right?
I don't know the ways. Okay, let's do IVUS again. Down.
Even this
Looks
did
okay.
not cross yet.
No.
You need to go a little further.
Yeah, I will. It
Yeah.
is okay.
Done dozens and dozens of bifurcation calcified cases. No two cases have been the same.
Yeah, that is correct.
There is always learning involved.
Okay, now we can IVUS here.
And right through this case, two of the world's best, most experienced operators continue to change the strategy.
That's correct.
Okay, down.
Now question is, what will the imaging add now, knowing that this was a tight lesion? IVUS did not go. We just went with a compliant balloon. Now we are a little far away. There, whether we use a cutting balloon or we use a IVL. So definitely atherectomy is out of question now. It's only remaining IVL versus
It came out.
everything good. IVL versus cutting balloon. What do you want to do? Or you want to decide by the imaging?
Okay.
Huh?
Since we decided, okay, get the imaging.
Okay,
Let's move fast.
good.
Based on the eyes, it looks good that compliant
You
balloon
have-
has done its
have-
job. But let's do the IVUS to see if we
Have
need any
the
additional
IVUS
atherectomy.
catheter already there.
Ready, yeah, it's
might
all
as
ready.
well,
No, yeah, IVUS is there, but we have
You have
ready
a
for the IVL
IVUS
2.5.
you have a IVUS catheter and an IVUS
Okay.
expert.
When we are talking, he talks.
I'm sorry, what? Stent will be 3.0 because of the Xience.
Yeah, it's
Good.
close. Okay, I check the image.
3.0
okay,
23 and
start feedback.
3.25
This is the diagram.
33.
Mm-hmm.
It's normal. Yeah.
Mm.
Some disruption. Eccentric calcium, but not severe.
Okay, it's just at 90, right?
Yeah, correct.
You want to
I
do
stop
the
it.
cut? So just at the ostium,
So this is the
90
level
degree?
of the LED D1 bifurcation. I
Yeah.
go inside. Yeah, it's true. Eccentric calcium, little bit protruding. So maybe we can say nodule, but 90 degree.
So we can use 2.75 cutting balloon here then, right?
hold on, go back to the diameter.
Yeah, it's
I'm a
good
little
point.
concerned about
So this is
275.
a reference like a 275 vessel, kind of relatively small vessel diagram.
Go to the ostium.
Yeah, so this is a bifurcation. So this is osteal diag. Eccentric plaque, calcified plaque, but not severe.
See, it's like 275 may be aggressive. Now, when you go back to the LED at the level of the
Clean.
bridge, okay?
So you go to the first bullet.
Yeah, first pull back. Give us the vessel size there.
Yeah, that part is 275 vessel.
25? You still want 275?
Yeah, and Dr. Kinney, there's a diffuse plaque to the osteal
2.5,
LED. So where do we cover? The osteal
Pay
proximal edge of the
attention.
stent is going to be Austere LED.
How many times?
I mean, not good landing zone on the IVUS, proximal landing zone on the LED.
Distal left main, show me distal left main.
So this is the left main bifurcation. Then this is a distal left main. Area is fine, but a lot of calcified plaque.
Very important, okay?
If you want crossover
Basic
to the
things.
left main, a little more proximally, good landing zone.
Ah, okay. And then go to that level of the bifurcation. Not bifurcation,
So this is the austere LED.
we got it.
Yeah. And from here to the distal reference is 24, just before the bridge.
Go near level of the bridge.
So then maybe 27524 or something. So
Three.
at the start of the first pullback, there is slight bridge, like 5 to 6
So the
o'clock.
vessel size was how much?
Like average is 275 vessel.
So 3-0, we can put 3-0. Maybe question is 38, go to the distal left main.
3O, I think, caused the dissection. That's what I'm trying to make a point.
A huge size gap. Actually, left main is like 4-5 vessel.
Yeah. So then you have to have 3-0. You are talking about left main 4-5 distally.
Okay, go up.
Okay. Go.
No, why we see the dissection in the LED is the vessel size, there barely 3O. And with the 3O vessel, how you went? Go. 18. Okay, down.
2.5 cut the Wolverine, we
Down.
went to 18 atmosphere.
Okay,
Yeah,
go up here.
This is the lesion was.
Okay, here you can go low pressure. Okay. Down. Go up here. Okay, so you want 3O.
Yeah. So try to let's understand in the earlier caudal view how bad is the distal left main and what is the ostial circ.
Go up here. Now you have to stent across.
Yeah. Yep.
Okay, down.
Good.
You want to take a caudal view picture?
No, we have it.
Okay,
already.
okay, yes.
I take this one out meanwhile without floor. Yeah, definitely there was a nice calcium in the diagonal, and it was true at the ostium only. Yeah, here. Now I think there is a tapering of the distal left main. I think we have to take care of that.
No, we will.
Yeah.
But we'll stand across.
38. Yeah, that's fine.
38 may be too long. He is saying 24.
That's to the austere.
33.
To the left main is going to be 32.
Not
32.
33.
33. Okay, they give us the first the side branch. Let's get a picture and let's get a side branch.
So, I mean, just hit our highest number of viewers at the moment, just to provide you feedback. And the specific question again coming from Nikhil Jha, I'm going to read it. I think it's
side branch.
important for all to know.
Yeah.
What is your preferred stent platform for left main LED stenting considering
275,
expansion
23.
limits and strut density?
I can tell you this, all are just very theoretical. As long as you can exchange the increase up to 1 millimeter more. That is it. And all stents perform very well. There were some original data or synergy.
Hold on.
But if necessary, we use synergy Megatron. One of the registry,
Hold on,
IRIS registry did show that
What are you
synergy,
opening?
had a slightly higher trouble in the left main. But then in those cases, we go with the synergy Megatron. But I think all the stents are good. They can be increased by 1 millimeter. Don't go more than 1 because then your strut density decreases. And I think the cutoff is usually the stent to vessel ratio of 16% has been ideal. We learned from the data of our multi-links and so. So I think I would not go beyond. People do say that, the synergy team, BSc will say, or others that, you can increase our stent to 1.5, 2 millimeter. No. So in this particular case, if the left main is distal about 4.2, I'll put a 3O stent and then you can dilate up to 4O. So that's, and I think there is, because there is no comparative data. There is no comparative data difference between two of them. All 3, 4 of stents. So what did we put in the side branch now?
We are putting a 275, 23.
Okay, good. Okay, that's fine. Leave it. And then we are ready with the 33.
3 or 33.
3 or 33. And key is that to have a different type of inflator so that you remember whether you put a sticker or we actually have the white inflator versus our regular inflator. Which company is the white one? Which company makes the white, this one? Mad Lab, okay. And our regular inflator are Boston Scientific? Yeah. So try to just make it so that they are different. See, the Namic are the one. And also always important when you're putting a stent in the left main, make sure you at least have a 7-8 millimeter because you don't have, we do have a 6 millimeter pot balloon.
Can we put a mini crush of the non-left main?
Yeah. On the data set, show there.
On the
bifurcate. That's it. Too far. No, then you need longer. Will not cover your left main.
No, it's good. It's good.
Huh?
It's good. Some dye now.
Okay. Good. Leave it.
Non-left main, mini crush, Felipe.
He has it.
Okay, some dye. Yeah.
And
see?
advance more.
It's a lot.
Advance the LED. This is the LED.
Okay, now.
You
We are advancing the.
You can do a little more if you need to be.
No, no, no.
Okay. Ready? Take a picture. Then
Hold
we
on.
start.
By for the
Pull back left. No,
main.
diagonal is good. Actually, very good.
Okay.
Maybe it will be
Ready?
too much now. Yeah.
Have to go in with the LED a little bit.
Both.
Right?
Both. Right?
Yeah.
Even diagonal. Look at the diagonal. Lot of overlap. Both 2 millimeter in. This is the.
So for our viewers, this is possibly the key learning moment.
Okay, some dye.
Absolute
I think looks good.
precise positioning.
That looks good now.
Okay,
Ready?
now dye for the diagonal.
Okay.
Pulling back. Some dye for the diagonal again. Okay, good. Go off with the diag.
Yep. So diag is so very clear. So no confusion. We are there. It's a 2.75. So we go 14 atmosphere.
Eesh.
As our steps are, which are playing, that balloon
some
is
dye.
out, little dye, and then wire out. Good. That's it.
Okay, now some.
No, this is okay. LED is good.
No, some dye. I have to just make sure that okay. Okay, go up.
Go up. 14. No, go again. 14. Just leave it for a few seconds.
Yeah, these guys, they go up and come down.
No, the Huda is teaching them. You have to give few seconds. I mean, we are fast, but at some point you have to be. Let a balloon inflate.
Yeah, be fast at the right right step.
Right step, yeah.
Not with the inflation deflation.
Actually, there was a study one time showed that 60-second inflation give you better MSA.
Because it takes that long for the dye to reach there.
Good. Take everything this out.
No, we needed the wire. Probably is gone now.
Yeah.
Get us a new fielder wire.
Okay, we are going to see the pictures now. Good.
Fielder wire is okay.
Yeah, new fielder wire.
No, I think it's good.
Okay, let's take a picture. Wire further. Anytime you make sure the spring portion of the wire is not in the lesion, you'll never see the dissection otherwise.
Dark
it has
portion,
to go distal.
Another nice point for people to learn. The
Okay, ready.
greater
Go.
visibility will, these are small little, very, very practical points. Okay, looking excellent, excellent.
Yeah.
Ostium
Okay.
looks
Little
fine.
massage. Yeah. Go. Rewire. Give us a 408 high pressure balloon.
I think we didn't cover the distal part of the
Go.
dissection of the LED.
When the distal, that little massage will be good. Both LED and diagonal, there is a little disruption distally. But to me, that type can be taken care with just balloon dilatation.
Okay, get us a new fielder wire.
So, I mean, the observation of one of our viewers is that maybe the calcified portion of the diagonal did not really get treated as well, because that part of the stent looks a little underexpanded. It's a very good observation. I don't think
we've seen it.
Yeah.
We did it. We see it there. We are going to post dilate there.
Yeah, we are going to post dilate. No, of course we are going to post dilate now. Yeah. See this now. We did a plaque modification with a 2.5. Question is, could we have done with a 2.75? No, I think looks good. Nice explanation. Now here we are. And now we should be able to post dilate that area. And we have we can take the 2.75 12 high pressure balloon.
Diagonals are notorious for perforation.
Get the compliant balloon which we had before.
Diagonals are notorious for perforation, especially when you're using cutting balloon with high pressure. If you have noticed that when I told the fellow go 18-20 atmosphere at the ostium, but as we went to the body of the diagonal, we went about 12 atmospheres.
So two things here, which is the strategy change. That you can dilate your LED, so strut becomes a little better. Will be easier to cross. That's one way. Or if it's easy, that's what we always say. That do you do a part versus any difficulty? So in this particular case, knowing there is a disparity of the vessel size and the stent.
You have the balloon?
Yeah, 408 balloon. Yeah.
Give it.
So leave that wire. Yeah. Yep.
Not even that. Once there was a calcium at the level of the bifurcation, we always find crossing, recrossing can become an issue.
Yep.
What's that they have?
This is
For what?
this after we cross the diagonal with the compliant balloon, which we have already.
What's the compliant balloon you have?
We had 2.5 before, right? Yeah. Good.
Okay, let's go.
Yeah. Good.
Okay,
Okay,
go.
going up.
You don't go.
No.
Okay.
12.
Okay, done.
And at the ostium also you can go 6 at atmosphere. It was barely 3.0.
Actually wanted the
Yeah, that's okay. Low pressure will be okay. 6,
okay.
8.
Done.
Want to hear?
When there is that. Okay.
But just doing a low pressure 6 atmosphere with the 4.0 balloon, which is all right. Okay.
Pain?
Yeah, good. Okay, now let's
We need
wire
a
it.
3.0 for the LED when we recross, right?
Yep. We had a 3.0 balloon already for the LED earlier. That's what we are going
That's
to
a
use.
20. Right?
Yeah, that's
Find
okay.
it easier. Not
LED will
easy.
use it, yeah. As long as the diagonal goes in first. Yeah.
We may need a 2.012 balloon for the diag first.
You want to get 2.012 compliant first? Okay. Give us a 2.012 compliant. Not this one. That was a 2.5. 2.5 compliant. So we are going with a new balloon for the diagonal, not the old used one, because that may give a little difficulty.
What is this?
This is just putting a 3.5 there. Yeah.
Not 3.5.
3.0. The old 3.0, which Yeah. We got a new 2012 compliant balloon. Let's do a kissing, and then I go to our angiographic, our didactic discussion. Good.
Okay, go high. Really open it.
Yeah.
I would have gone 2.5 because that
So we had a
area of the
2.5. We had 2.5. 12. We had a 2.5. 12 earlier one.
Okay.
Yeah.
Now it's 2.75.
Yeah, we are 2.75, 12 now. Yeah.
I do not want 2.75. I think we go 2.5 high pressure to open that diag.
Not 2.75.
No, I think it's too big.
Anu and Samin, 41 people watching now.
Beautiful. Beautiful. Good. Okay. What are the balloons we have? Huh?
High pressure?
Yeah. No, we don't need compliant. Now you need a non-compliant balloon.
So bread and butter bifurcation case brings up sophisticated audiences.
Yeah. Okay, this is,
High pressure?
Yeah. So we want to just say picture so that I can, while you're optimizing, then you'll do IVUS once we are ready.
Yeah.
Meanwhile, your wire has come back.
DCB time.
Huh? You start your lecture.
Yeah. Good. Maybe I want to just take a picture and maybe massage all the distal segments.
Okay, take a picture.
Okay. Good. Just little distal edge massage. Okay. Meanwhile, we can go up talk about our. Meanwhile, they're going to do a kissing balloon and then imaging, and then we'll come back. Okay, let's go. Meanwhile, our presentation.
What is this?
So what we are going to talk about is the recent trials of DCB, PCI, and imaging. The agent multi-layer ISR outcomes, ISR test 2 study, DCB Circo registry, then IVUS guided PCI versus cabbage in left main or 3 vessel CAD. And our focus review of the month is peri-procedural myocardial injury using CKMB following elective PCI. And incidents and associated with the long-term mortality. Some recent data came out from the registry from NYU. So what we learned is we knew agent IDE, ISR, but DCB did extremely well compared to balloon angioplasty. Now question was, why there a differential effect in multi-layer stenting versus single layer? So this basically was that, remember the trial, original trial of about 600 patients, of which 258 were multi-layer ISR. So, and 341, so it was like 52-48%. The differential, and both were either paclitaxel versus uncoated balloon, and see the outcomes at 1 year on the right side. Seems to be that once you have multi-layer ISR, the benefit of DCB was far superior compared to single layer. And that's what we expect, whether it's a target lesion failure or TLR. So basically showed that once you have multi-layer, your balloon angioplasty is not a good, and that's what we don't do. We always do either drug-coated balloon or, which we have been traditionally doing it, intravascular brachytherapy, IVBT. And this basically was the conclusion. Second was they actually had a nice editorial by Roxana. In terms of treatment of multi-layer ISR lifetime management, reason is patient comes back, but then patient still has to come back again. So what is basically concept is evolving that your first PCI, your ISR, either you do another DES, which is the class 1 indication, as you know, or the DCB at present. And then, but only thing is, once you DES, now you got the multi-layer, and multi-layer has a high trouble. So once the multi-layer has a recurrent ISR, your third stent is not a treatment. Either you DCB or you do a brachytherapy. And of course, imaging is a crucial on that. Second, If you have a DCB, you came back with ISR after first you do a DCB, it leaves you the chance that you do a DES. Whether you can use another DCB, which we do not know, and that's not, I would say, is a strategy. Second, that these lesions have to be purely, you need to optimize them appropriately by plaque modification. Whether using the atherectomy, cutting balloon, pure balloon angioplasty do not work, as we know. Now, there are ongoing 3 trials at present. Solution ISR, which will be presented next week in TCT. Magical ISR, we were the lead enroller in the solution ISR of the 68 patient. Then Magical ISR is ongoing. And then lastly, the Prevail IDE. Prevail is the paclitaxel. Other 2 are using the sirolimus. Then this is the trial to see which one is better. Remember, in the DES era, we have a multiple trials of the DES, whether sirolimus better, paclitaxel better, and so on and so forth. So now we have the trials of the sirolimus coated balloon or paclitaxel eluting balloon, and this is the TIS ISR2 study from Czechoslovakia, and basically showed that, as you can see the late loss point of view, that in the whole concept was the non-inferiority. So BMS cases, there were non-inferior, other cases were no different. So this turns out to be that the trial failed to achieve the target, and that was that SCS is non-inferior, rather it was inferior because the late loss was a little higher compared to paclitaxel. Individual later date points are here, and more importantly, binary restenosis was not different, which was exactly 30% in both the groups, and there is no difference in the acute outcomes as shown here. MACE, TLR, TVF, stent thrombosis, and so. So kind of it failed. So this basically was the non-inferiority of the sirolimus eluting balloon compared to paclitaxel was not demonstrated in this study. So therefore, no good. So paclitaxel still remain a better approach as shown by this study. Third was the using the DCB into the side branch of the circumflex in de novo vessel compared to DES. And this was the international from Italy, the various predictors between 2 matching lesions of the using either the DCB versus the stenting for the side branch. And you see before propensity match, I think we should get after the propensity match, which is on the right side, about 1:2 ratio, and basically showed that DCB did exactly what it's supposed to do. No difference in various outcomes. TLR, TVF, no difference basically in these cases. Compare and the myocardial infarction, and so you can say that if you want to use these are the 2-year outcomes, the DCB is a good approach for the side branch, irrespective of the vessel size. Although I think that because there was actually trend towards p-value was 30 in the DES and DCB was 17.5, favoring DCB compared to DES. So although I think that in real life we didn't find any difference of those. These are the individual graph. So it puts it together that in the matching population, despite the DCB patient has a longer lesion length and more calcification, more imaging was used in those cases. And of course, DES has a lower fluoroscopy time and contrast use. So clearly that, but outcomes were not different. So this can say basically that the DCB is a good option for the side branch of the left main. Ostial circumflex. Third is that does IVUS make a better in terms of our outcomes with the left main and 3 vessel disease with the 3 studies, the Renovate Complex PCI, all were done from Korea. Then long-term outcome of the prognostic factor patient undergoing cabbage or PCI study, which is Samsung Medical Center, and then long-term outcome of prognostic factor in patient undergoing cabbage or institutional cabbage. So all 3 centers, multi-center, institutional center, and so they combine angiography guided PCI about 1,000, intravascular guided PCI about 848, but cabbage about 5,000, and basically showed that PCI was lower bad outcome, or I would say higher MACE rate compared to cabbage. We understood that even with a propensity match, the PCI has a higher outcome compared to cabbage. Second point was, if you do imaging, you can think in the center. The basically cabbage plus intravascular imaging outcomes are identical at 3 years. So that is the key. So imaging basically eliminated this difference. And of course, the angiographic had a higher event rate compared to cabbage group. So conclusion basically trial was that once you the intravascular imaging, your outcomes are similar to cabbage in this multivessel and left main disease. If you do angiography alone, your outcomes are worse. So this basically was the conclusion of this. Then lastly, the focus review of the month was the new data on the peri-procedural myocardial injury using CKMB following elective PCI, incidence and associated with long-term mortality. Remember, we have published quite a bit of many papers on this issue, including troponin and MBs. And basically, this is again from the large database of the NYU Medical Center, about 10,000 plus cases. And myocardial injury means any CKMB elevation occurred in about 17% of cases. And they have the various predictors of the where it occurred, in particularly left main lesions. And no difference in the atherectomy, as you can see there. Overall, with individual, I mean, atherectomy definitely higher, but others were not much different. And the high-grade lesions, of course, will have a higher event rate. But more importantly, the probability of survival was no myocardial injury and or myocardial injury defined as CKMB elevation, followed up to the 5-7 years, thus showing that continued trend. Separation of trend, hazard ratio of 1.43, and that's interesting because usually we always said the low-level CKMB or troponin not associated with higher mortality, but not in this study. In this study, it was more actually right from the beginning, except 1.3 time CKMB. After that, it was a linear relationship with the adverse outcome of mortality. As you can see here, they call our CKMB ratio. So this was a unique paper in the sense, until now we have been teaching everyone that up to 5 times elevation, and you know the SKY definition for 4A MI is 10 times. That lower than that is not associated with higher mortality, but this paper said it otherwise. And that you can see even any 1 to 10 times elevation is associated with bad outcome, as in shown here. 1 to 10, more than 10. So a little surprising. And so myocardial injury defined by elevated CKMB early after PCI is common, occur in 17% of cases and associated with all-cause long-term mortality. More complex anatomy is predictive of post-PCI myocardial injury. So this basically they put it together. Everything is a nice graph. So just to say, what we learn extra in this particular case, in this is that we have the linear relationship of the CKMB. Whether it's maybe earlier data we have up to 1 year follow-up, and so maybe long-term follow-up will be different, and that is what this paper is all about. So just to sum up, agent DCB versus balloon angioplasty in multi-layered DSISR, even much better outcome compared to single layer. Then the sirolimus eluting DCB versus paclitaxel, it kind of failed, did not meet the non-inferiority. The DCB over DES for de novo ostial circumflex lesion looks good. Actually, very interesting. Then IVUS guided PCI versus cabbage in left main 3-vessel disease. Yes, thumbs up. Then lastly, the recent registry data reported linear relationship of post-procedure CKMB elevation with long-term mortality in elective PCI and can be reliably predicted by clinical and angiographic factor. Although this report is in contrast to many earlier publications, including from our Mount Sinai database, where only more than 5 times CKMB elevation correlated with long-term mortality. Therefore, extra care can be extended to these patients with predicted post-procedure CKMB elevation, such as aggressive antiplatelet therapy, atherectomy, use and extended post-procedure observation. So let me go through my 5 questions quickly, 3 questions quickly. One is the randomized TIS2 trial showed similar 12-month MACE, similar 12-month TLR, similar stent thrombosis, similar late lumen loss, similar acute gain. Answer is D. No, it was lower late loss in paclitaxel versus sirolimus. Then following are the true statement regarding the results of the angio versus imaging guided PCI versus cabbage in left main and 3-vessel disease at 3 years. Similar MACE rates between IVUS, intravascular imaging guided PCI versus cabbage. Angio guided PCI had higher MACE rate versus imaging guided PCI. higher TLR with imaging guided PCI versus CABG, similar death rates with imaging guided PCI versus CABG, and similar MACE rates between angio guided PCI versus CABG. Answer is wrong is E, because it's a higher event rate, MACE rate with the angio guided PCI versus CABG. Lastly, recent report of correlation of post-procedure CKMB elevation on long-term mortality showed the following, except similar CKM elevation post-atherectomy, only higher mortality with CKMB elevation more than 5 times. Bifurcation lesions have similar CKMB elevation. CKD patients have higher CKMB elevation, and PAD patients have higher CKMB elevation. So clearly, B, only higher mortality with CKMB elevation more than 5 times was wrong, because there was a linear relationship of any CKMB associated with the mortality. And we are here now for come back to the angiogram, because Anu has finished the case and they're finishing the IVUS. Anu, with you.
Yeah, now it's opposed.
Opposed?
Yep.
Okay, show us
Distal
the
left
angio
when
now.
everything is okay?
Fluoro. Yes, show the last picture and then the imaging.
That the area of the diag is not fully expanded. Question is, do we go with 275 or leave it? Distal edge of the LAD looks okay?
We didn't check.
Huh?
We didn't do IVUS.
Distal edge of the LAD with the first run.
That's the diagram.
No, we did LAD.
Okay. I'll show you the picture.
LAD had not been done yet. Yeah.
For this
we did not
pullback,
do the
there is a
LAD.
smooth transition.
So I think that diagonal, one of our observer, Dr. Zha, I think pointed that out. I think we need a 2.75 higher pressure. That stent of the diagonal has not been fully expanded.
Yeah.
And that's what I always wanted to mention. We have the balloon here.
We also knew it.
Yeah, so we had 2.75 balloon now. So that's it. Besides that, everything looks good. I think if you want, we can conclude.
Yeah,
right?
we should conclude.
Huh?
It's like,
So we are just going to post-dilate the diagonal. And if it's okay, Samir or Anu, you want to continue or you want to just end it now?
Samin, we have 36 people watching. I think would be good to continue.
Continue. That's fine. Yes.
Just to provide you a feedback on a few people, a little bit of a provocative findings on the CPK MB, which I think is to be expected. It goes against our long-held feeling that a higher CPK MB was the one. But the finding that there is a linear relationship is kind of not that that much of disparity or shock. But I want to.
Yeah, no, that is true. Some studies have shown in the past, but majority of them has shown, and particularly we have it with the post-procedure MI, troponin elevations, and so. And I know only thing is in this one was CKMB, and they call it as a myocardial injury. They didn't call it MI because many of these cases did not have any remote universal definition 4A. Require patient have chest pain, EKG changes, and MB elevation. But in these particular cases, they did not say anything whether they did not have the data, whether patient has chest pain and has the EKG changes. So less than that. So therefore they call it as a myocardial injury. So that I think is the right word. So it truly maybe the CKMB, and only problem is only 1.32, which is the CKMB ratio. So once it became, let's say, 2 times, it was associated with a higher mortality. That's where the difference comes down to compared to other studies where it showed 5 times. Some people have said 3 times with some clinical event. It's associated with a follow-up event rate. So we are a little different from that point of view in this study.
How would it clinically correlate?
There basically was that.
Do you discharge the patient?
Yeah, that's the question was. So they have did second value between 1 to 1 hour and 3 hours. That was the institutional protocol. So every patient had those CKMB. Just like us, we have it 1 hour and between 4 to, we have one at the baseline and between 4 to 6 hours, and patients are admitted because the MBs were elevated. Or other inpatients, we do another one between 16 to 24 hours. So question comes down that what difference, when do you measure it? Every patient had it was actually state mandated long time ago, and then they took it away. But then we continued to measure, and just like NYU, they continue to measure. That's what their database is. And that basically just showed. Now, question is, if you have high MB and has a mortality advantage, what you do differently? So what our policy was very simple, that if your MB is elevated, you repeat after a few hours and discharge the patient only when MB is going down. So you have taken the peak. And if the MB was more than five times, every patient had an echocardiogram, and secondly was started on ACE inhibitor and beta blockers if there was no contraindication. So those are the strategy which you use. And third is use a stronger antiplatelet therapy if possible. If you're not worried about bleeding and patient was on clopidogrel, we change them to prasugrel or the ticagrelor, or usually prasugrel. So knowing that the stronger antiplatelet therapy is expected to protect from these myocardial infarction, although in this particular study, there was no difference of the discharge antiplatelet therapy.
Okay, go.
Start to work. From LAD.
It makes complete sense what you are mentioning. I don't think there should be any disagreement at all, but it will probably need to be reflected in the guidelines also at some stage, the diverse management, what happens when the CPK levels are, there is a disparity here, but interesting topic. I think this is not the last we are going to hear about it.
Yeah, that is correct. All right, I know how things are now.
So we see there is a IVUS pack there.
Yeah, done. Yep, looking good. Left main is good, LED looks good. Little dissection. There's a distal edge dissection actually in the left. How bad is the dissection? That's the question.
So
Of which one?
This is
Of the LED. See that dissection right there?
Yeah, we know that. But that was the thing about
More
remember,
than 2.
No, the issue was, remember I kept saying we need to go forward because I was worried we never covered it. But I think we can leave it now because we are reaching a level where everything is getting very complicated.
Yeah,
every
bridge,
movement
so-
of every balloon, every wire was like very difficult.
No, but tell us, people talk about some arc like 70-degree arc, 2
But
millimeter
that's in
length.
OCT.
Yeah, but still the same criteria may apply here because you have what is the width or dissection width or so, or arc of dissection which you are worried about.
So anyway, it's not. I don't think it's come to the media. So like intimal dissection and the flap. So like almost 90 degrees. So actually the cutoff is 90 degrees.
Really?
So
90, okay.
kind of borderline.
I see.
How much is the length of it?
Yeah, that's a good point.
I mean, some people will use that 5 millimeter cutoff also, no?
2 millimeter actually.
Yeah. Okay.
Like level of.
I mean, I would do.
Yeah, this is
in
also
this
like-
kind of case, I'm the only user. 2 bolus of integralin and be happy.
Okay, 2 millimeter. 90 degree, 2 millimeter.
Yeah.
So exactly sitting on the fence.
Yeah.
Yep.
It looks very good here.
Angiographically will do nothing.
Yeah.
At the end, EYE wins.
Yeah.
The other part stent is well expanded. Proximal looks opposed, so well expanded.
All right. Very well expanded. Okay, so we can make the
I just need
conclusion
to
of
show
the...
you one thing when we were recrossing. Where are we? Yeah, we did all that, right? Was it this? Yeah, this was the post you saw, right? We recrossed.
Yeah.
We had left you around this point.
Yeah.
Yeah, I know. Okay, you see here, normally we left the balloon in the diagonal. We wanted to go into the LED. Would not go. You see that?
Yeah.
So when we are trying this, we got to be cautious because you have the stent in the mid part of the left main. So then we remove the diagonal balloon and then the LED balloon advanced. So it can't be too aggressive, otherwise there's a chance of LSD of the the left main stent. That's another reason also, it's like now rewiring it and again balloon. We did balloon of the distal edge of the LED, but going back stenting, I think there's time when you have to say leave it alone because there's a risk of destroying the left main stent by trying to get a perfect let me finish. Several trying to get a perfect result of LED diagonal.
Anush, just to, because what you're speaking is exactly the sentence. Majority of the people have mentioned, agree, leave it alone.
Okay. Yeah. And as you know that many times, almost the October trial showed, once you do OCT, almost 18% of cases, you have either go through the strut or behind the struts. And so clearly stent deformation is a reality, and we should be very cautious about it. And particularly when you're using imaging. Now, not every case of the stent deformation will create a trouble, but key is that it's on a long run, maybe not 1 year, which are the data 1 to 2 years, maybe in 5 years. But the idea is, I mean, just to data are that almost like 1 in 7th case, when we rewire and when we do the bifurcation, we go through the underneath the struts or in between the struts, which is very common finding.
So total fluoro time is 29 minutes, 08 seconds, and air karma is DAP. We haven't even reached 1.
Yeah.
So next time, I want to do a case without imaging, and let's see the fluoro time.
Yeah. It will be how. All right.
Anu, excellent skills, great teaching points. Kiski, thank you also. Samin, great topics to talk. We end our session here and we'll see you on November the 18th.